Hello, my name is Dr. Miriam Kamarami. I'm the medical director for the Graken Center for Addiction at Boston Medical Center. Today I'll be providing a presentation sponsored by the Boston and Cambridge Hospital Consortium, which is supported by the Graken Center for Addiction at Boston Medical Center and by RISE, Massachusetts. Today we'll be focusing on understanding problems related to substance use. All of us care for some patients who have problems related to substance use. For some of us, treating substance use disorder is our main clinical focus. Others of us do not seek out these patients, but we end up caring for them because substance use is a problem across all boundaries of age, gender, race, ethnicity, and socioeconomic class. If we increase our understanding of problems related to substance use, we can all provide better and more appropriate care for our patients. A recent survey of providers in Massachusetts on their attitudes towards substance use disorder uncovered some problematic misconceptions and lack of understanding. Only 1 in 4 providers had received training on addiction during medical education. Less than 50% of emergency medicine and family and internal medicine providers believed that opioid use disorder is treatable in spite of copious evidence to the contrary. Twice as many emergency medicine providers, compared with any other specialty, believe that methadone treatment for opioid use disorder is just substituting one addiction for another, in spite of the evidence. All of us have something in common. We all started out as babies. No baby ever decided that she or he would become addicted to heroin or other opioids, develop alcohol use disorder, or develop problems with cannabis. But some babies and children start out in this world with a much greater risk of developing problems with substance use. In this presentation, we'll talk about why some of us are much more vulnerable to developing problems with substances than others. And we'll also talk about ways that we can reduce risk and provide effective treatment for anyone with a substance use disorder. As we grow from infants to children to young adults, our risk of developing problems with substances changes. We may begin with an inherited risk of developing these problems. For instance, this may cause our experience of using substances to be stronger and more pleasurable than it is for other people. On the other hand, other people have lower inherited risk. For instance, they may inherit a trait that makes it unpleasant to drink alcohol, and so their risk of developing alcohol use disorder is lower. We may grow up in a culture in which people commonly use substances as part of social interactions or with meals. Or we may grow up in a culture in which young people use substances to fit in or as a coping mechanism for stress, anxiety, or trauma. Also, the impact of legalization of cannabis in our society may have the effect of reinforcing a perception of social acceptability and therefore indicate to young people that they don't need to be concerned about risk. We know that factors that cause us to start using substances at an earlier age increase the likelihood that we will develop a substance use disorder as adults. This could be because we were offered substances when we were very young, or because we grew up in a very stressful environment and were seeking escape. A big part of our risk of problems with substance use comes from experiences during childhood that are called adverse childhood events, or ACEs. The term adverse childhood events refers to a group of childhood experiences that predict later problems with physical and mental health, including increased risk of developing a substance use disorder. As you can see in this diagram, adverse childhood events are divided into 3 main categories: abuse, neglect, and household dysfunction. Abuse can include physical and sexual abuse as well as emotional abuse. Neglect can be emotional or physical. Household dysfunction, as defined in the original studies of adverse childhood events, included someone watching their mother be treated violently, household mental illness, having a household member who's incarcerated, parental separation or divorce, and substance use disorder in a member of the household. Felitti and colleagues found in a large survey of Kaiser members that most reported having experienced at least one adverse childhood event, and 1/5 of the sample reported 3 or more adverse childhood events. They also found that experience of adverse childhood events was correlated with the development of a wide variety of later health problems. In particular, they found that each ACE was associated with a 2 to 4-fold increased risk of early initiation of drug use, which in turn is associated with greatly increased risk of developing a substance use disorder. Many subsequent studies have confirmed this relationship in a variety of different populations. Researchers have found that childhood experiences of ACEs increase the likelihood of developing all of these problems and many more. What are the biologic mechanisms underlying these relationships? Research shows that adults who experienced adverse childhood events as children have higher levels of stress hormones and markers of inflammation, and these likely play a role in greater susceptibility to physical and behavioral health problems. So you can see that people who experience ACEs did not make a choice to have a high risk of developing problems with substances. Their brains tend to respond differently to stress and to be soothed by substance use, and this increases their risk of developing problematic use. When we understand this, we can see why it doesn't make sense to blame people who have problems with substances. So many different factors influence my risk of developing a substance-related problem. My genes, my family, my culture, my access to substances, and things that happened to me when I was a baby or a small child. If we didn't understand these things, we might be inclined to blame people for their substance-related problems rather than treating them for their disease. In the following video, a patient describes the impact of receiving supportive, respectful care for her substance use disorder.
I was using heroin for around 6-7 years before things started to catch up. I didn't know who I was. It just changes your brain chemistry and it changes who you are so much. You know, I was a little girl. I was a little girl and just a shell of myself. My name is Sherry. I grew up in Massachusetts. I'm currently in school for biomedical engineering, and I'm raising my 7-year-old daughter, and we also have a dog. When I came into treatment, there was just so many pieces to work on, and you know, I'm this tiny, frail girl, and I had never really learned any of the skills needed to function in life. I was scared. I was afraid to ask for help. I was afraid to talk to anybody. And I've been fortunate. All of the people that I've worked with, from the front desk to nurses and doctors, everyone has always treated me the same. They've seen me change. I look nothing like I did before. I speak nothing like I did before. You know, we change so much profoundly. And my nurses and my doctors are right on board with that. And you know, they always ask me, like, how is school going? How is this going? You've come so far. Like, remember when you were in that shelter and now you're in this house, and you know, you're doing such a good job, and it means so much. Sometimes we don't have people to tell us that.
It is amazing what an impact we can have simply by being respectful and helping our patients to have hope. So, how do people develop problems with the use of substances? When we take a step back from it, it is really kind of strange that we humans develop addiction to some substances, but not to others. Why don't we have an addictive response to lisinopril, say, or to metformin? Why can we only develop addictive behaviors in response to some substances? Research has shown that the brain has a particular pathway that is activated by all of the activities that we find pleasurable. This reward pathway is activated by eating food when we're hungry, by drinking water when we're thirsty, by sex and all of the things that we consider appetites. It's also activated by interpersonal relationships, spirituality, exercise, art, music, and beauty. The common reward pathway in the brain for all pleasurable activities involves the neurotransmitter dopamine. And it makes sense that humans have evolved to take pleasure in things that keep us alive, help us bond, and help to perpetuate our species. Remarkably, the drugs that can cause addictive behavior hijack this natural pleasure circuitry of the brain. These drugs act as an imposter, activating the powerful symptoms that compel us to engage in activities that can help us to stay alive, but they don't deliver on the promise to help us thrive. In this slide, you can see that all addictive drugs act directly or indirectly via dopaminergic pathways. All substances that cause addictive behavior increase dopamine levels in the pleasure pathway in our brains. In these graphs, you can see the impact of exposure to certain activities on the dopamine level in the brains of rats. You can see that when a caged rat is exposed to food when it's hungry, it has a spike of dopamine. Similarly, when a male rat is paired with a female rat and has sex, there's another spike of dopamine. Natural rewards stimulate dopamine neurotransmission. Eating something that you enjoy or being stimulated sexually can cause dopamine levels to increase. In these graphs, dopamine is being measured inside the brain of rats, and the increase is shown in response to food or sex cues. This basic mechanism of controlled dopamine release and reuptake has been carefully shaped and calibrated by evolution to reward normal activities that are critical for our survival. Here you can see the response of the rat brain to various substances. The response in some cases is stronger than the response to sex. The spike in brain dopamine levels from amphetamine is 5 times as great as the levels produced by sex. The tiny graph in the inset panel shows the relative size of the peak of dopamine in response to sex compared with the peak caused by amphetamine use. No wonder addictive drugs overwhelm the balance between pleasure-seeking and cognitive override. The intense stimulation of the dopaminergic system causes people to do things that don't make sense unless we understand the power of the compulsion produced by these overwhelming stimuli. Our brains did not evolve to be able to handle this type of stimulation, no matter how smart we are or how strong our willpower is. We are left with a brain that is conditioned to prefer drug over non-drug rewards, and that overall has a harder time appreciating all rewards due to an increase in the reward threshold caused by changes in the brain with chronic substance use. In the next video, a physician describes his struggle with substance use disorder and the ways in which the drug altered his thinking.
My name is Peter Grinspoon. I'm a primary care physician at the Chelsea Healthcare Center at Mass General Hospital. I'm a person who suffers from addiction, and I've been in recovery from addiction to opiates for 10 years. The drugs served a number of different purposes in my life on a number of different levels. Superficially, they were entertainment and rebellion. You know, I studied very hard in medical school, and they were sort of a throwback to my wilder days at college or when I used to work at Greenpeace, and they were like a freer, rebellious me, and they were entertainment and a break in the routine. But as I got further and further into my addiction, you develop a really close emotional relationship with the drugs. It sounds really strange, but it's really true. This is a really, really important part of addiction. And you start to lose your emotional relationships with people and start to supplant these emotional relationships with people with the drug, which is why, in a lot of ways, addiction is a disease of isolation. So increasingly throughout medical school, residency, and then as I graduated to become kind of a doctor, primary care doctor, the drugs became my emotional support. They became what would help me when I was sad, lonely, anxious, and they became what I'd celebrate with when I was happy. They really became my emotional life. And it's really scary because as the drugs were doing this, I would let my other relationships wither because they just weren't as important to me as the drugs. Very insidiously, the opiates take over your brain, and they take over the part of your brain that's aware of the fact that they're taking over your brain. So it's just very difficult to know what's happening, and you don't really see it day by day. But then years go by, and all of a sudden, you find yourself sort of lonely and cut off from everybody. And the only way to deal with the loneliness at that point is to take more opiates. So the problem becomes very self-reinforcing.
In spite of all that we know about the causes of substance use disorders, there is still a tremendous amount of stigma associated with these conditions. Stigma interferes with people seeking treatment, and it also sometimes interferes with us being willing to provide life-saving treatment for people with substance use disorders. Why do you think it is socially okay to express stigma toward a few groups, such as people who use drugs or are obese, but not so much towards others, such as people with physical disabilities? One answer is that we classify these particular problems as due to our own choices rather than as diseases. But do you think a child who has experienced multiple adverse childhood events or a baby born with a genetic predisposition is just making a bad choice when they develop a substance use disorder? We all recognize that stigma is not just something that comes from society at large. We in the health professions exhibit marked stigma toward people who have substance use disorders. What are some examples of stigmatizing language used by professionals about people who have substance use disorders? You've probably heard all of these terms used in a professional context at some point. Even a term like drug of choice implies that people are choosing to be addicted rather than having a chronic disease. The terms dirty and clean are frequently used to describe the status of a urine drug sample, but they're also often used to describe human beings. Think for a minute about the way that staff in an emergency department or clinic talk about a patient who has a substance use disorder compared with a patient who has heart failure, and yet the two conditions may be equally likely to kill the patient. What are some negative consequences of stigma toward people who use drugs? In addition to feeling unnecessary shame, patients may avoid seeking treatment or avoid seeking care for other problems because they're trying to avoid stigmatizing attitudes. They may be isolated, face harsh legal action, experience denial of services, and find inability to get work or to find housing. Researchers Kelly and Westerhoff surveyed more than 500 clinicians attending two separate mental health conferences and randomly assigned them to read a vignette describing someone as a substance abuser, or an identical vignette that described the person as having a substance use disorder. They then asked about the clinician's perception of the patient and thoughts about how the patient should be treated. Comparing responses to a person with a substance use disorder versus the substance abuser, the substance abuser was felt by the respondents to be more likely to be personally culpable or responsible for his condition. Respondents were also more likely to feel that his problem is caused by a reckless lifestyle and he is responsible for causing his problem. Clinicians were more likely to agree that punitive measures should be administered to the substance abuser than to the person with a substance use disorder, including a statement that he should be given some kind of jail sentence to serve as a wake-up call. Clearly, words matter. The first step in reducing our own stigmatizing beliefs is to recognize what we are thinking and to question it. For example, we might catch ourselves thinking, someone who has a substance use disorder is less worthy of my care than someone who has another type of disorder. Stigma is often also combined with lack of knowledge. For instance, in a recent survey of Massachusetts medical providers, the RISE study, 50% considered substance use disorders to be untreatable. It's also important to recognize the intersectionality of racial bias and stigma related to substance use disorders. The epidemic of opioid overdose deaths has been attributed to deaths of despair among white middle-aged American men. But think about it. Did anyone ever refer to the crack cocaine epidemic, which disproportionately affected Black Americans, as representing deaths of despair? Why was that epidemic criminalized while the opioid epidemic, which disproportionately affects white Americans, is addressed through treatment? After we recognize our own stigmatizing thoughts and language, we can work on changing our language. This chart shows some examples of stigmatizing language on the left and more clinical or professional language on the right that you can substitute. We could launch a campaign in our own institutions to raise awareness of the damaging effect of stigmatizing language and to suggest alternatives. What else could we do to address substance use disorders? In the next video, a patient describes how effective medications for opioid use disorder have been for him.
My name is Efren Lozada. I am a recovery coach / peer support specialist for Charlestown Mass General Hospital. Anything to do with me having to do work with myself, I didn't want to do it. You know, pretty much if it had been up to me, without the consequences, I would have just done a self-will. But I actually, I found out I couldn't do that. In my early days, there was no medication-assisted treatment program besides methadone, and that is one thing that I didn't want to do. I never wanted to do methadone. People were telling me, well, doing methadone is just like doing heroin. That's what they would put in my head, and I grew up with that. So I said, well, I'm not going to do that, you know. So that's why, when I was finally able to put down the heroin, I stuck to the cocaine or the crack cocaine or the alcohol, which was minor to me. But I swore I would never do anything like that. No methadone. To be honest with you, if I had medication-assisted treatment when I was trying to get clean and sober, I probably would be clean and sober much longer than what I am now. Working at Mass General at Charlestown Health Center, I work in the medication-assisted treatment program as a recovery coach under the SUDS initiative. And I have a caseload of maybe about 151 patients. Now, I don't see them all because, of course, they all go their separate ways or they relapse and come back. Suboxone is one of the medication-assisted treatments that we have, which for many of the patients we serve works, and for some it doesn't. You know, then we have Vivitrol, which is the injection every 28 days, and for a lot of people that works. There are so many people that I work with that are success stories. You know, in the process of talking about going back to school, getting jobs. And, you know, I don't know what it was like before I got to Charlestown Health Center, and I didn't really know much about the medication assisted treatment program until I got to MGH. And I'll tell you, they're miracles. They're miracles, and they're lifesavers for people. Suboxone, Vivitrol works. There's evidence all over Boston.
Whether we work in primary care, other clinical settings, including surgical clinics, the ED, or inpatient settings, there's actually a lot that we can do to address substance use disorders. We can screen, and screening may be easier than you think. This single item screening question has reasonable sensitivity and specificity and is quick to administer. Providers often worry about screening because there are limits in what to do next. One of the points we'd like to make today is that for opioid use disorder, you are no longer helpless. You can start treatment with buprenorphine in most cases or refer to treatment. The goals of medications for treatment of opioid use disorder include alleviating physical withdrawal and craving, blocking the euphoric effect of other opioids, reducing or eliminating risky substance use, helping to normalize brain function, decreasing the risk of injection-related harms, and preventing overdose. There are 3 medications that are currently approved by the FDA for treatment of opioid use disorder. The oldest is methadone, which is a full opioid agonist. Buprenorphine is a partial opioid agonist, meaning it partly activates the mu-opioid receptor in the brain. And naltrexone, which is an opioid antagonist. Detox has no effect on long-term outcomes. Maintenance treatment with medications is the key to success and has been shown to reduce relapse, injection drug use, overdose, infection with HIV and hepatitis, crime, and incarceration. Medications have a much stronger evidence base as a standalone treatment than does psychosocial treatment. However, behavioral health approaches to treatment are very important to help patients to stabilize and to address co-occurring disorders such as depression and PTSD. On the left side of this slide, you can see when someone first starts using a substance, euphoria is the main effect, and function is preserved. With chronic use, tolerance develops, and euphoria is replaced by needing to use in order to avoid withdrawal. Medication treatment aims to restore normal functioning by eliminating both euphoria and withdrawal and returning the person to a psychological and physiologic state that is similar to their pre-drug use state. Methadone has been used in this country for some 70 years. It's highly effective, and it works by fully activating the mu-opioid receptor in the brain. It's very long-acting, and the dose is titrated only every 3 or 4 days. Patients are dosed 1 time a day for opioid use disorder, whereas methadone that's being prescribed in a doctor's office for treatment of pain is dosed 3 times a day. So who can offer methadone for treatment of an opioid use disorder? Only designated opioid treatment programs operating under the auspices of the federal government are legally allowed to offer methadone for treatment of opioid use disorder. It is illegal to prescribe methadone for treatment of OUD in general practice. Methadone's once-daily dosing allows patients to get out of the cycle of addiction, namely binge and intoxication, withdrawal, and then preoccupation and anticipation, which gets in the way of everyday life and allows their brains and behavior to stabilize. In spite of the stigma surrounding methadone, the evidence is clear that methadone is highly effective as a medication for retaining people in treatment and preventing adverse effects, including death. Methadone is offered all over the world, and methadone and buprenorphine are among the WHO list of 100 essential medications that should be available worldwide. Some of the benefits of methadone include daily observed dosing, which provides structure that is helpful to many patients. A multidisciplinary approach, since counseling is required along with medication. It's also been very well studied with the benefits that I mentioned earlier, and there are very good treatment retention rates. Limitations include the risk of overdose because of its full opioid agonist effect, which occurs mainly in conjunction with use of other substances that have a sedating effect. Medication interactions, which are many. The slow titration also results in a longer time to stabilize on an adequate dose. There's poor access in rural areas, and there's a risk of QT prolongation, leading to a risk of dangerous cardiac arrhythmias, although this has been questioned in some recent studies. The environment of a methadone clinic may also be a trigger for relapse, since patients may be in contact with people with whom they previously used drugs. And last, the stigma and the inconvenience of having to show up every day for an observed dose are both significant deterrents. Buprenorphine is a partial activator of the mu opioid receptor. However, it binds very tightly to the receptor, so it's long-lasting. Buprenorphine is formulated with naloxone as a deterrent to injection. By combining buprenorphine with naloxone, this encourages the patient to take the medication under the tongue, sublingually, as a medication, rather than dissolving it and injecting it, which could increase its intoxicating effect. When the medication is dissolved under the tongue, the naloxone is inactivated, but if it is injected, it is active and can precipitate withdrawal. Who can prescribe? Physicians who have Data 2000 waivers, the so-called X waiver from the federal government, which requires an 8-hour training course. As of 2017, nurse practitioners, physician assistants, clinical nurse specialists, clinical nurse anesthetists, and certified nurse midwives may take both the 8-hour data waiver course for treatment of opioid disorder that physicians currently take and the additional 16-hour course offered to meet the requirements for the Data 2000 waiver for these professionals. Supervising physicians, if they're needed in these professions, must be DEA waivered as well. With most opioids, the higher the dose, the stronger the opioid effects, with increasing effects up until the point of respiratory suppression and then death. Because buprenorphine is a partial activator of the mu opioid receptor, it has a ceiling for its intoxication and also for its respiratory suppression effects, and by itself it does not seem to cause overdose deaths in adults. However, when combined with benzodiazepines or with large amounts of alcohol, overdose death is possible. And it's important to note that there is a high risk of overdose death if buprenorphine is accidentally consumed by babies or by toddlers. Among the benefits of buprenorphine are that it does have a lower risk of overdose and sedation than with methadone. It also has very few medication interactions, unlike methadone. It's prescribed in an office-based setting, and so patients have privacy and the convenience of getting a prescription for a medication rather than daily observed dosing. And so treatment can be integrated into primary care practice. Buprenorphine can be an important tool when problems arise during chronic opioid therapy for pain. If patients develop opioid use disorder, switching them to buprenorphine can treat their opioid use disorder as well as treating their pain. We also know that home induction is safe and effective. In other words, patients can start themselves on buprenorphine at home rather than having to be in an office setting and have observed induction. Limitations include limited access to the medication due to reluctance on the part of healthcare providers to prescribe the medication. Also, concerns about the risk of diversion. Injectable, long-acting buprenorphine may provide a solution to the concerns about diversion, since it's injected once a month in depot form and is active for a full month. Another important public health impact of pharmacotherapy for treatment of opioid use disorder is that it's associated with a community-wide decrease in the risk of overdose deaths. You can see here a study from Baltimore in which the dashed line shows the increase in availability of buprenorphine treatment, and the red line shows declining rates of heroin overdose that appear to reflect the increase in buprenorphine availability. Notably, methadone availability was high and went higher during the course of this study. Unfortunately, some patients are more likely to receive access to buprenorphine than others. Recent work from Lagasetti and colleagues shows that while the number of buprenorphine visits is rising nationally, white patients are far more likely to receive a buprenorphine prescription than are patients of any other race. In addition, private insurance or self-pay were more common methods of payments than Medicare, Medicaid, or other. What about treatment with naltrexone? Naltrexone, unlike buprenorphine and methadone, is an opioid antagonist. It binds to the mu-opioid receptor and holds onto it tightly, preventing any opioid medication from attaching to the receptor and activating it. Patients must be off of all opioids for 7 to 10 days prior to starting naltrexone, since buprenorphine as an antagonist can cause acute withdrawal. 2 formulations of naltrexone are available: an oral 50 milligram daily dose, which has been shown to be largely ineffective for opioid use disorder, and an extended release injectable form that's injected in a dose of 380 milligrams intramuscularly monthly. No special licensure is required in order to be able to prescribe naltrexone, unlike buprenorphine or methadone. Some benefits of naltrexone include that there is no withdrawal if the medication is stopped. Also, it's effective in treatment of alcohol use disorders, so it's an excellent treatment for patients who have co-occurring opioid and alcohol use disorder. Naltrexone does not cause respiratory depression or sedation. It's not a controlled substance, and so there are no restrictions on prescribing. Early retention appears similar to that achieved with buprenorphine if successful initiation is achieved. Some limitations were noted in a couple of recent publications. A structured review concluded many individuals intending to start extended release naltrexone do not, because of the need for complete abstinence for a period of time prior to starting. And most who do start extended release naltrexone discontinue treatment prematurely, 2 factors that limit its clinical utility significantly. A population-based study of patients in the year after non-fatal overdose in Massachusetts found that both methadone and buprenorphine decreased all-cause and opioid-related mortality, but did not find this for naltrexone. Median treatment duration was 5 months for methadone, 4 months for buprenorphine, and 1 month for naltrexone. However, the authors noted that the results were somewhat uncertain due to the small number of patients who were treated with naltrexone. In the next video, a patient who has become a recovery coach talks about the long-term nature of the disease.
Setbacks are very common in people trying to, get a handle on their addiction. And I've experienced setbacks for, over a decade, before I was able to kind of get a handle on it. It's, it's just kind of par for the course. It's very rare that I hear that somebody gets this on their first try. Had to try many different things before I was able to, find what worked for me in terms of, long-term recovery. I tried to not let this thing kind of defeat me, you know what I mean? And it's very easy to do, it's very easy to kind of throw in the towel and just kind of have that thought of, I'm going to be an addict for the rest of my life. It's, I can't get this thing, but, and that's where I think, healthcare professionals, family, friends can really help by not letting someone give up.
It is important for anyone who is at risk of having or witnessing an overdose, including friends or family, to have access to naloxone or Narcan that can be used to reverse an overdose and save someone's life. Populations at particular risk include users of syringe exchange programs, people who have recently exited from incarceration, those in drug treatment, those who are prescribed opioids, and anyone who is in treatment for opioid use disorder, has a past overdose, or is co-prescribed opioids and benzodiazepines. The website prescribetoprevent.org has some excellent information on implementing naloxone programs. Naloxone is available for free at needle exchange sites, and both MassHealth and Medicare plans cover the cost of a naloxone prescription. Most private insurers also cover naloxone prescription, and naloxone is available at most Massachusetts pharmacies without need for a prescription. One just needs to ask in order to get access. So let's take a step back and think about what would be an ideal state based on all the information that we've discussed today. We would have immediate access to medications for treatment of opioid use disorder for all patients who need it, and naloxone co-prescribing for everyone at risk of having or witnessing an overdose. Medical providers would receive comprehensive training in pain management as well as treatment of substance use disorders. We would also benefit from having a comprehensive data dashboard to track outcomes of prevention, screening, prescribing, treatment, and more. And comprehensive care would be available for patients with substance use disorders that incorporates their social determinants of health and other behavioral needs. We can combat stigma, which is such a ferocious barrier to obtaining adequate treatment for substance use disorder. We can implement screening in our practices, and we can expand overdose prevention and naloxone distribution. We can organize our primary care and emergency teams, as well as other qualified providers, to provide medication treatment for opioid use disorder. We can collaborate with behavioral health providers to provide comprehensive treatment for substance use disorders, and we can address social barriers to health. In short, it's important that we treat addiction in order to save lives. Thank you.